Hello, everyone. My name is Tab Jagger. I'm a critical care paramedic at Perry County Ambulance Authority here in Hazard, Kentucky. And today we will be discussing the lethal trauma diamond, previously known as the lethal trauma triad, and what it means to us in EMS. So let's jump right in with some learning objectives. So we're going to describe the lethal trauma diamond, identify the parts that make up the diamond, and identify and describe how the lethal trauma diamond affects patient outcomes. And we're going to kind of discuss briefly how to minimize the effects. So first, what is the lethal trauma diamond? So the lethal trauma diamond is a set of 4 physiologic factors that can lead to further blood loss, hemorrhagic shock, and even death in our patients with traumatic injuries. So previously it was believed that coagulopathy, acidosis, and hypothermia were the main reasons for the high mortality rate in our patients with traumatic injuries. However, recent studies have shown that hypocalcemia plays a crucial role in our trauma patients, and it also affects the previous 3 factors. So with that being added, we've gone from the lethal trauma triad to the lethal trauma diamond. So we'll jump right into the first part, which is acidosis. So acidosis in trauma patients is a metabolic state that's described by a pH level that is less than 7.35. And the main reason for acidosis in our trauma patients is a metabolic process where the body switches to anaerobic metabolism to produce energy, and that causes an increase in lactic acid production, lowering the overall pH level in the blood. So let's go on to why it matters. Why does acidosis matter? So it plays a huge role in increasing the mortality rate of our patients. It could lead to more negative patient outcomes. It also reduces the body's clotting factor, reduces cardiac contractility, and it disrupts the body's cellular process and can lead to organ damage. All 3 of those things are very important in our trauma patients. Like, we want the body to have the most conducive environment to using natural clotting factors. We obviously want the heart to keep pumping that blood round and round, so we want to keep the heart as healthy as possible, and we also want to minimize any sort of organ damage, because that could lead to longer hospital stays, longer recovery times, and more negative outcomes of our patient. Some of the ways that we can reduce acidosis in our patient is proper oxygenation, stopping blood loss, and hypothermia management. Hypothermia management we're going to talk about here in the next leg of the diamond. Limiting crystalloid infusions, so we don't want to just drown our patients with normal saline or lactated ringers. We really want to just give them the minimal amount to keep the appropriate map based upon our protocols. And we'll push on to hypothermia. So hypothermia management. Hypothermia is at baseline the core body temperature dropping below 95 degrees Fahrenheit or 35 degrees Celsius. Hypothermia in our trauma patients is extremely deadly, and it will lead to negative patient outcomes. And it's always something that we want to manage before they're in a hypothermic state. It's easier to prevent it than it is to treat it. Some of the ways that we can do this is make sure that we're covering the patients in dry clothing or blankets, increasing the heat inside the ambulance, using that ambient temperature and really bumping that up. Still, that is less than ideal. Even if we have the heat on, we still want to keep them covered up. Make sure that they have dry clothing on, and we should be cutting off any sort of wet clothing or anything to do our trauma assessment. Another thing is using warm fluids whenever possible. I know fluid warmers aren't something that every ambulance service has, but we'll try to minimize that by not putting cold fluids in them. An important thing to remember with hypothermia, that even if the patient is in a warm or hot environment, we still need to be thinking about hypothermia management, because with blood loss and everything else and cutting all their clothes off, they could still have the chance to become hypothermic. So let's talk about some better hypothermia management. Commercially available products, there's a ton of them out there. The best one is the North American Rescue HPMK. It's considered superior because it comes in one singular package. It has active heating element, and it also has reflective heating element, as well as a head covering. And it's just one kit. You have everything in there. You don't have to go looking for anything. And as we said before, make sure that we cover the patient's head. We all know we've all been out in the cold before, and if we don't have a hat on, a lot of that heat escapes through our head. Another thing that we want to consider is limiting the openings and exposure during movement and reassessment. We're going to have to take serialized vital signs. We're going to have to check to make sure that our treatments and our interventions are still holding up. So when we do that, we want to open, check, close back whatever we're using for our hypothermia prevention. That's really important because we don't want to leave all that stuff exposed and leave the ability for them to become hypothermic. Let's move on to the next part. Alright, so before we move on to the next part, we'll talk about some commercial products. In the top left corner, we have a ready heat blanket, your standard space blanket, and a head covering. Those are really the minimum items that you need. We got the head covering. The active heating element is like a giant hand warmer that when it's exposed to air, it'll heat up. One thing, if you do use these things or come across these things, we don't want to put them directly on the patient's skin because it could cause burns. Usually they don't get hot enough to do that, but we don't want to take that risk. Just under that, we have like an orange space blanket type thing. It's a pretty good commercial product, but as you can see from the picture here, that there's no head covering. So we would have to find a sheet or a blanket or some other means to cover up the head. Up at the top, I have a little picture of the HPMK. As you can see, it's like multi-layer heat protection. It's going to hold in their body heat. There's a head covering. There's an active warming element. It really has everything you need in one package. Alright, let's move on to the next portion. So coagulopathy. Coagulopathy is a bleeding disorder that reduces the body's ability to make clots. Coagulopathy could come from many different avenues. They could be medically driven or trauma driven. In this case, we're talking about trauma patients, so it's referred to as trauma-induced coagulopathy. It's just a way to decipher the difference between medical-induced coagulopathy and trauma-induced coagulopathy. Often, coagulopathy itself is diagnosed by using laboratory tests that aren't necessarily available to us on the ambulance, so we might not be aware that the patient has coagulopathy issues unless we're told, such things as like blood thinners and previous medical history during our history taking portion. Some factors that contribute to TIC, which is the trauma-induced coagulopathy, is hypothermia, which we talked about already, acidosis, and hemodilution, which we also touched on a little bit, and we'll touch on more here in the next section. Shock is also a big factor that reduces the body's ability to make clots, specifically decompensated shock, when the body's just shutting down. It doesn't have the defense mechanisms to kind of shunt all that extra energy to creating clots. So those are kind of 4 factors that we want to look out for to help reduce the chance that the patients will develop coagulopathy. So managing and reduction of coagulopathy. So blood product administration, which we're going to talk about a little bit more in the next section. Limiting the amount of crystalloid fluid administered. It's been on a couple slides already because I think it's super important that we don't flood our patients with crystalloid solutions. Our body doesn't run on normal saline or lactated ringers. We really need to be driving home that blood product administration. Hypothermia prevention, stopping the blood loss, and acidosis prevention or correction. Alright, finally, we're getting to the last section here, hypocalcemia. So hypocalcemia is basically just a reduced amount of calcium in your body. It can be found to significantly increase the mortality of our patients with blood loss. It could exacerbate hemorrhagic shock. And the way it does this, it binds to the lactate and lactic acid, and it further drives home the acidosis in our patients, as well as lowering the amount of calcium available in our bodies. Hypocalcemia can increase the need for multiple units of blood once they reach the definitive care, and we want to try to avoid longer hospital stays and negative patient outcomes. Some signs and symptoms: muscle cramps, tingling in the hands, feet, lips, spasms of the throat that could lead to difficulty breathing, confusion, and seizures. We also may observe prolonged QT intervals, so it's would be wise of us that while we're doing our secondary assessments or just kind of extra assessing of our patients, that we throw them on a 4 lead or do a 12 lead just to check all this stuff out. With giving blood products, we talked about how important it is to give bloods over crystalloid fluids, but blood products contain citrate. Citrate can lower the available calcium in our trauma patients. It binds to the calcium, making it unusable by our body. So, how do we combat that? What we want to do is that if we're giving blood products, we want to make sure that we give our patients calcium. So the initial dose is 1 gram of calcium. It can come by 30 mLs of 10% calcium gluconate or 10 mLs of 10% calcium chloride, IVIO, and we want to give this after our first unit of blood. We also want to redo the dose after every 4 units of blood. So it's always safe to remember that if we're giving blood, give some calcium with it so we can prevent hypocalcemia in our patients. Alright, so we talked about all 4 factors that contribute to the lethal trauma diamond: acidosis, hypothermia, coagulopathy, and hypocalcemia. Keeping all these 4 factors in mind when we're dealing with our trauma patients is going to reduce the mortality, reduce hospital stays, and have better patient outcomes. It's always important to keep these in the back of your mind while you're assessing and treating these patients. That concludes my presentation. If there's any questions, feel free to ask them in the comments or message, and I'll try to get the answer and get back to you as soon as I can.